The last batsman of WCCPCI is Dr. Sampath Withanawasam. He is a consultant cardiologist at the General Teaching Hospital from Kagal in Sri Lanka. He will be speaking on non-compaction cardiomyopathy and arrhythmogenic RVOT cardiomyopathies, a case-based review.
Good evening, chairpersons, ladies and gentlemen. First of all, let me thank the organizing committee giving this very valuable opportunity to Sri Lanka Heart Association. My aim is today in this evening to share a couple of interesting cases with you. The arrhythmogenic right ventricular dysplasia and non-compaction cardiomyopathy. We'll go straight away to the case report 1. It's a 24-year-old lady, previously completely healthy. Basic investigations were normal, including ECG. These are pre-op investigations. And she had undergone thyroidectomy for atypical cells in FNAC. Unexpected cardiac arrest after the full recovery, same day of the surgery. And after initial resuscitation with shocks and the normal drugs, the failed resuscitation, patient died. You can imagine the situation and the scenario of this type of after this type of situation. So this is the ECG we retrospectively seen, and the first strip is the upside down, but the second strip you can see where we are mainly interested on leads V1, V2, V3, which are right precordial leads, completely normal in this lady. Postmortem findings, surgical site uncomplicated, which was the main worry, and saved the surgeon. The heart weighted 240 grams and valves, myocardial thickness and coronaries were unremarkable, including the right heart. Other organs were unremarkable to the naked eye. So the histology was taken from each and every side, including the right side of the heart, and this picture shows the histology of the right heart, which shows it's obvious that a lot of fatty tissue infiltrate in the myocardium. So fatty replacement of the right heart, and which was patchy actually. So the diagnosis was obvious after the postmortem, but obviously too late. The right ventricular arrhythmogenic dysplasia or arrhythmogenic right ventricular dysplasia. We'll go through very shortly what this disease is. It's genetically determined heart muscle disorder, predominantly autosomal dominant, but rare cases were reported for autosomal recessive genetics, especially Nexus disease, well-known disease, which present with woolly hair and palmoplantar keratosis. Fibropathy replacement of the right ventricular myocardium is the pathogenesis and the hallmark of the disease. Usually starts at the inflow tract of the right ventricle as well as outflow tract and the apex of the RV, which we call triangle of dysplasia. Sometimes you may see the diffuse right ventricular disease as well as left ventricular involvement, and in rare forms now they have identified left ventricular disease predominantly. And this is the triangle of dysplasia, which involved right ventricular outflow tract, right ventricular inflow tract, and the apex of the RV. And the right side picture shows that the dilated and thinned right ventricle, and ultimately which goes into a picture like dilated cardiomyopathy, where you get the involvement of the left ventricle also. The disease presents usually sudden cardiac death. Most of the patients are presenting with sudden cardiac death, like with our experience. But syncope, presyncope, palpitations, and incidental ECG or echo findings, and sometimes in late stage with heart failure, are the other forms of presentation. The investigations and criteria for diagnosis. I'm not going for a full diagnostic criteria for this disease, which involve major and minor criteria. None of the single criterion is diagnostic of the disease. So we have to have either two major criterion or one major and two minor, or otherwise four minor criterion to diagnose the disease. The echo is the most useful because it's widely available, inexpensive. Regional RV, akinesia, dyskinesia or aneurysm, and with right ventricular outflow dilatation. If it is parasternal long axis, it's more than 32 millimeters, and parasternal short axis view is more than 36 millimeters, confirm a major criteria. Another modality is MRI, especially if you can't see the right ventricle in an echo properly. There you can see regional RV akinesia or dyskinesia and dysynchronous RV contractions, and also that can be utilized to calculate right ventricular end-diastolic volumes and the right ventricular ejection fractions, again which is useful for diagnosis of the disease. RV angiography is almost diagnostic and the gold standard test for the disease, where you can see regional RV akinesia, dyskinesia or aneurysm, where you can see in this picture RAO 30, right ventricular angiography. You can see multiple small aneurysms, which is due to dyskinetic segments or akinetic segments forming the inferior lateral wall. It's quite characteristic picture in right ventricular arrhythmogenic dysplasia, and histology proves the final diagnosis. In your left side is the left side is the normal histology of the heart. You can clearly see the right side is the same picture that we have got from our patient with the fatty degeneration or fatty infiltration of the myocardium. Other histological form is fibrofatty degeneration, which is not seen in our patient. It's only the fatty tissue here. Right. The most important, I think, from our point of view and the clinical practice for day-to-day life is if we can identify this in a ECG, may be very valuable. But unfortunately, ECG findings are very subtle and very easily can go miss. And 10% of the patient can get absolutely normal ECG like in our patient. Here you have to see the ECG changes in the right precordial leads, that is V1, V2, V3, where you can see T wave inversions. Unfortunately, this pass as normal, especially in adult female and in the presence of ischemic heart disease. The other important thing, if you can concentrate on that, the V1, V2, V3, the slight widening of the QRS complexes is more than 110 milliseconds, and the last part of that is the neither of the S waves to beginning of the ST segment, that part is more than 1.5 small squares. It's very difficult to see in a normal ECG. But more classical ECG changes include epsilon wave, which is a spike after the QRS complex. But I'm sure if you are not concentrate on, if you are not seeing this clearly, or if you are not suspecting, these things can go miss easily. VT, non-sustained or sustained VT, especially left bundle branch block morphology, if it is coming from inferior or lateral wall, which indicate in the ECG as the leads 2,3 AVF negative, 2,3 AVF negative, that gives some clue. And again, even with the otherwise, the positive QRS leads in 1, 2, 3 AVF, that is RVOT origin. The VTs doesn't exclude the disease, it includes a minor, confers the minor criteria. Frequent ectopics, more than 500 ventricular ectopics per 24 hours, again a minor criterion to diagnose the disease. Family history, familial disease in a first degree relative, confirmed at necropsy or surgery, or identification of pathogenic mutation. Treatment is, of course, suppression of arrhythmia, the beta blocker, best is sotalol, and other agents, amiodarone. The heart failure treatment, I'm not going to discuss as usual. ICD implantation. In rare cases, to reduce the burden of ventricular ectopics and VTS and VF, RF ablation will be useful. Lifestyle modifications, especially avoid heavy exertion and avoid cardiac stimulants, will be helpful. We'll quickly go to the case report 2. This is a 37-year-old unmarried carpenter presented with a 19 years history of easy fatigability, shortness of breath of exertion, atypical chest pain, palpitations, and loss of appetite and loss of weight. Had smoking history of 10 years and heavy alcoholic, but was stopped 5 years ago. Very significant family history. Mother, shortness of breath for 3 years, monoparesis of the right upper limb, dense right-sided hemiplegia a year later, and died at the age of 42 following a bow knee amputation of the right lower limb for a gangrene. So it's multiple episodes of embolic phenomena. Father, sudden death at 42 years. The post-mortem was not done, was not known. 2 siblings are healthy. So the ECG controlled AF, Holter, few runs of SVT and VT. Coronary angiogram was normal, especially because of a history of smoking. We have done the coronary angiogram, and 2D, I have the still picture. So this shows the echocardiogram picture, which is of course diagnostic of non-compaction cardiomyopathy. It's again a very rare form of cardiomyopathy. Now we see with the understanding more commonly. Non-compaction cardiomyopathy is a rare form of congenital cardiomyopathy, first identified in 1984. It's a new disease and mutations were recorded. The diagnosis again mainly by echocardiographic diagnosis, but you can miss for some other diagnosis if you are not carefully looking to the apex and the lateral wall. The main features in echocardiography, you should definitely exclude the other causes of cardiac abnormalities, and compacted epicardial band and a thicker non-compacted endocardial layer of trabeculation and deep endomyocardial spaces, which makes the whole stone of the diagnosis, cornerstone of the diagnosis. Predominant localization of the pathology of 2 left ventricular mid-lateral apical and mid-inferior areas, and color Doppler evidence of deeply perfused intratrabecular recesses. So all these features explained in this picture very nicely. Non-pacted myocardium towards to the left with plain 2D echo, and you can see the measuring of the myocardium, the thickened myocardium towards to the pericardium, and non-pacted compacted myocardium towards to the endocardium, and you can demonstrate deep recesses with the color Doppler, and which is almost diagnostic of the disease. The MRI is a useful diagnostic tool for difficult cases, and these patients classically present with the heart failure symptoms, the ventricular arrhythmias, and systemic embolic events like our patient's mother. So treatment basically depends on symptomatic treatment of heart failure to suppress ventricular arrhythmias, and for prevention of systemic embolic events there is a place for warfarin and other forms of anticoagulation. So summary: knowledge regarding prevalence, genetics, diagnostic and morbidity and prognosis of genetic cardiomyopathies is limited but accumulating. Earlier mistaken for other forms of cardiomyopathies. Awareness of the genetic cardiomyopathies will increase diagnosis of new cases, and with the facilities that we are having at the moment, probably with the knowledge, we are more and more diagnose this type of rare forms of congenital cardiomyopathies. So thank you very much for patient listening. And thank you very much and congratulate as the last speaker for your very successful Congress. And we'll hope to be there next year also. Thank you very much again.
Sampath, very nice and elegant presentation describing rare cardiomyopathies. I have one question here, unless somebody has any question. Anyway, now actually the second case was easy. I'm a non-compaction cardiomyopathy, easily diagnosable, but the RV dysplasia is really a subtle one. A lot of people miss it and it could be in trouble.
Yeah.
So what are the clinching, how would you have made a diagnosis if somebody checked this patient prior to surgery, she was only 24, that's could have been prevented. What are the clinching points of diagnosis?
Unfortunately, in this case, I don't think that there is any way of diagnosis because 24-year-old, otherwise healthy lady without having significant family history, I don't think that any anesthetic will consider any investigation other than ECG. Maximally echo, still I'm doubt. So I don't think that the only thing that here the problem is, I don't know why in the hospital setup we couldn't resuscitate this lady. So that's still a problem. But other than, I don't think that the pre-op, because ECG is 100% normal, we couldn't find any abnormality and she's perfect. So
Okay.
I doubt that we could diagnose this case before the procedure at that age.
Okay. The Sri Lankan team playing in India played very well. Played at the last ball as 6. Now, Captain is there, Dr. Kanayaka gave an excellent talk giving a review of cardiomyopathy, and all three spoke about cardiomyopathy. Is it common, is it true that Sri Lankans suffer cardiomyopathy more than any others?
Okay, thank you very much, Chairpersons, and thank you, Dr. Withanawasam.